Welcome back to the deep dive. Today, we are looking at laryngeal carcinoma. And I have to say, looking through the research on treatment, it feels like this really grim game of choose your own adventure.
It really does.
You have two main paths, surgery or radiation. And, well, honestly, both of them seem to carry a really heavy cost.
That is the reality of head and neck oncology. It's that classic tension between, survival and function.
Right.
We want to cure the cancer. That's obviously job number one. But we also want the person to be able to talk and swallow and breathe afterward.
Of course.
Because if you kill the cancer but you leave the patient unable to communicate or breathing through a permanent hole in their neck, you have to ask yourself, what was the cost of that cure?
And this is where that term organ preservation keeps coming up in all the sources. The standard thinking seems to be, prefer radiation because it saves the voice box.
That's the theory.
But looking at the data here, I think I'm seeing a flaw in that logic. If a tumor has already, say, chewed through the cartilage or destroyed the vocal cords, aren't we just preserving a broken structure?
That is the key insight. It's the crucial nuance that a lot of people miss. The hypothesis of organ preservation, it assumes the organ is still functional.
But it might not be.
Exactly. If the larynx is already destroyed by the malignancy itself, radiating it often leaves you with a non-functional organ anyway. You just end up with a stiff, scarred, useless voice box.
So sometimes the conservative choice, trying to save the organ, is actually the wrong one.
Precisely. It's about being realistic about what you're actually trying to save.
Okay, so we've got this high-stakes decision right up front. But before we get into the how, the mechanics of the beams and the knives, let's talk about the backup plan. The literature keeps mentioning this acronym, PORT.
Right. PORT, post-operative radiotherapy.
So basically you cut it out, but then you decide to zap it anyway.
Kind of, but you don't do that for everyone. PORT is essentially the cleanup crew. You bring it in when the surgery reveals that the situation was, well, worse than you thought.
So it's not the standard plan A.
No. You pull the trigger on PORT when you see certain high-risk features. For example, if the tumor was much bigger than expected, what we call T3 or T4 lesions,
okay,
or if the surgeon couldn't get a clear buffer of healthy tissue around the tumor, that means you have positive margins.
And I saw one phrase on the list that sounded particularly terrifying. Extracapsular spread.
Ah, yes, that is the big red flag.
What does that actually mean?
So cancer spreads to the lymph nodes, right?
Mm-hmm.
The lymph node has a capsule, like a little shell. Extracapsular spread means the cancer has grown so aggressive that it has busted out of that shell.
Wow.
And it's now, rampant in the surrounding neck tissue. That is an automatic trigger for PORT. You just can't trust the surgery alone at that point. You need the radiation to sterilize the whole area.
It's like the castle walls have been breached. Okay, let's unpack the primary treatments. Let's start with the ray gun approach, radiotherapy.
The ray gun, I like that.
When I read about this, I pictured a single machine, but the sources list a whole arsenal. You've got teletherapy, brachytherapy, IGRT.
It is an arsenal, and the technology has evolved massively. The standard workhorse is teletherapy, or external beam radiotherapy.
And that's the classic setup. Machine outside, patient inside, beam goes through the skin.
That's the one. But then you have the high-tech stuff.
Yeah, I was reading about this CyberKnife. It sounds like something from a sci-fi movie. Is it just a fancy brand name?
It's actually a very specific tool, a 6 MeV linear accelerator. But the magic isn't just the power, it's the reach and precision. The CyberKnife is often used for tumors in really inaccessible places, like the skull base.
Places where you can't really fit a scalpel?
Exactly. If you try to operate at the skull base, you risk hitting the brain or major nerves. The CyberKnife is like a sniper rifle. It uses image guidance to deliver a massive, targeted dose to that specific spot while sparing the normal tissue around it.
So it's a sniper rifle for hard-to-reach spots. That makes sense. But here's where I got a bit lost in the math. The fractionation.
Yes.
You don't just go in and get zapped once. It's weeks of treatment. And the doctors are constantly tweaking the schedule. Hyper, hypo, accelerated. Why mess with the standard daily dose?
This is fundamental to understanding how radiation kills cancer without killing the patient. Think of it as a race against two clocks.
Okay.
Clock number one is the tumor. It's trying to regenerate and grow. Clock number two is the patient's healthy tissue. It needs time to heal between zaps. Standard fractionation, about 1.82 grays per day, is the compromise. It's a marathon, usually about 7 weeks.
But then you have accelerated fractionation.
Right, that's where you speed up the timeline. You might treat the patient 2 or even 3 times a day. You are trying to outrun the tumor's regeneration. If you go too slow, the tumor cells can actually repopulate between sessions. Accelerated fractionation tries to kill them faster than they can breed.
Okay, so that's the blitz strategy. What about hyperfractionation? That sounds even faster.
It's the opposite logic, actually. You give more fractions, but with smaller doses each time. The goal there isn't speed, it's protection.
Protection for the patient.
Exactly. You're trying to sneak the radiation in under the radar of the normal cells to reduce long-term damage while still accumulating a lethal dose for the cancer over the whole course.
So one is trying to beat the cancer speed, and the other is trying to save the patient's tissue.
You've got it. It's a strategic decision based on the tumor and the patient.
And practically speaking, how do they aim this thing? Do they just blast the whole neck for 7 weeks?
No, they use what's called a shrinking circle technique. Phase 1 is the carpet bombing. You cover the primary tumor plus all the lymph nodes where microscopic cancer might be hiding. That's about 5 weeks.
And phase 2?
Phase 2 is the sniper shot. You shrink the field down to just the tumor itself for the final boost to get to that total curative dose.
Got it. So that's the beam. But we can't ignore the chemical warfare aspect. Chemotherapy. The literature goes deep into the cell cycle G1 S phase, mitosis. Is this relevant, or is it just biology trivia?
Oh, it's absolutely relevant. You have to remember, chemotherapy drugs aren't smart like we think of AI. They don't hunt cancer cells specifically.
Right.
They just attack any cells that are dividing rapidly.
So they're just looking for action.
Pretty much. The cell cycle tells us when a cell is vulnerable. For instance, the S phase is when a cell is replicating its DNA. Many drugs are designed to hit the cell at that exact moment to cause a catastrophic error.
And for the larynx, the weapon of choice seems to be cisplatin.
Cisplatin is the heavy hitter. The platin gives it away. It's platinum-based. The standard dose is about 100 milligrams per square meter. It's incredibly effective at stopping DNA replication.
But reading the side effects, it sounds brutal.
It is. It is a toxic drug. It attacks the kidneys. That's nephrotoxicity. It attacks the hearing ototoxicity. It causes neuropathy. You are essentially poisoning the patient just enough to kill the cancer and hoping the patient survives the poison.
That is a dark reality.
It is, and that's why patient selection is so key. If a patient is frail or has bad kidneys to begin with, they just can't handle cisplatin.
So then what?
That's when we switch to second-line drugs like 5-FU or the taxanes. But cisplatin, it really remains the gold standard because it works so well.
So we've radiated it, we've drugged it. Now let's talk about when we have to cut it. We're moving to surgical intervention, specifically the neck dissection.
This is a critical shift in thinking. Because laryngeal cancer loves to travel, we aren't just looking at the throat anymore, we're looking at all the lymph nodes in the neck.
And the surgery options seem to range from precision strike to scorched earth.
Scorched earth is a good way to describe the radical neck dissection, or R&D. For a long, long time, this was the standard.
What did that involve?
The surgeon would open the neck and remove lymph node levels I through V But they wouldn't stop there. They would also cut out 3 vital non-lymphatic structures: the internal jugular vein, the sternocleidomastoid muscle.
That's the big muscle on the side of your neck that lets you turn your head, right?
Yes. And the third one is the spinal accessory nerve.
Wait, they cut the nerve intentionally.
In a radical neck dissection, yes. The thinking was that it was necessary to ensure all the cancer was gone.
My God. What happens to the patient when you cut that nerve?
Well, that is the tragedy of the radical approach. It causes what we call shoulder syndrome. The spinal accessory nerve controls the trapezius muscle, that big muscle across your upper back and shoulder.
And we cut the nerve.
The muscle atrophies. It just wastes away. The patient's shoulder droops. It becomes painful, stiff. They lose the ability to stabilize their shoulder blade.
And practically, what does that mean for them?
It means they can't lift their arm above their head. They can't brush their hair. They struggle to get dressed. They can't pick up a grandchild. It's debilitating.
You save their life, but you take away their independence in this huge way.
Exactly. It's a massive quality of life hit. And that's why surgeons fought so hard to develop the modified radical neck dissection.
It's a functional approach.
Right. The goal became get the cancer, but spare the nerve. In a modified radical dissection, you still take out all the lymph nodes, but you carefully preserve the spinal accessory nerve and often the vein and muscle too, if you can.
Seems like this constant negotiation between being safe and being humane.
It always is. And sometimes you can go even more targeted with a selective dissection, where you only take the specific levels of nodes that are at the highest risk, leaving everything else untouched. You can only do that if the cancer hasn't spread too far.
Now we have to talk about the aftermath of all of this. Whether it's surgery or advanced radiation, the airway itself is often compromised. We need to talk about the tracheostomy, a hole in the neck.
A very common outcome in this field, yes.
First, a quick definition check. Tracheotomy versus tracheostomy, are they the same thing?
Not quite, though people use them interchangeably all the time. The tracheotomy is the surgical incision into the trachea. The tracheostomy is the result, the actual stoma, the skin opening that's created and maintained.
And I was surprised to read that this isn't just about breathing. It changes the patient's entire physiology. It's not just a new pipe. It sort of rewires how the body works.
It does. We call it laryngeal bypass. Because air is entering the neck directly and going straight to the lungs, it is bypassing the nose and mouth entirely.
Which means what?
Well, think about what your nose does. It filters the air, it warms it, and it humidifies it. With track, the lungs get blasted with cold, dry, unfiltered air.
That can't be good.
It's not. It causes the mucus in the lungs to dry up and crust over, which can block the tube. It's a constant maintenance battle for the patient.
And obviously the biggest one.
Yeah.
Speaking. If the air isn't going past the vocal cords, you're silent.
Generally, yes, unless you use some specific hardware.
Right. Let's talk about the tubes. I didn't realize there was such a menu of options. Silver tubes, PVC, cuffed, uncuffed.
It's a whole science. But for speech, the key feature you're looking for is whether the tube is fenestrated.
Fenestrated just means it has a window in it, right?
A hole, yes. A fenestrated tube has a little hole in the upper curve of the tube. This allows air to travel up from the lungs through that hole and pass through the vocal cords so the patient can speak.
But that only works if the vocal cords are still there and, working.
Correct. If the larynx was removed or is paralyzed, it won't help. But for many, that little window in the tube is the difference between silence and communication.
We should also talk about the cuff tubes. This sounded really important, especially in the acute phase.
Oh, essential. A cuff tube has a little balloon around the end. You inflate it to create a seal against the windpipe.
And why do you need that seal?
2 main reasons. If the patient is on a ventilator, the cuff makes sure the air goes into the lungs and doesn't just leak back up. Or if the patient is bleeding or vomiting, the cuff prevents them from aspirating that stuff into their lungs.
It's a safety seal. But you can't just keep it inflated forever.
Absolutely not. If you leave it inflated with too much pressure, it cuts off blood flow to the wall of the trachea, you get necrosis, the tissue dies. It's a really delicate balance.
So let's imagine the patient has gone through treatment, the swelling is down. How do they get the tube out? What's the exit strategy?
Decannulation. It sounds simple, but it's actually a test of endurance. You don't just pull it out and hope for the best.
What's the protocol?
You have to prove the patient can breathe through their natural airway again.
Yeah.
So usually, you start by capping or blocking the tube during the day while they're awake and you can watch them.
That must be terrifying for the patient.
It is. Imagine relying on that tube for weeks and suddenly someone plugs it. You have to trust that your throat is open enough to breathe. If they handle the day, then you try blocking it at night.
And that's the real test.
It is. If they can sleep for 24 hours with the tube blocked, no oxygen drops, no panic then, and only then do you remove the tube and let the hole close up.
And if they fail the test?
If they start gasping or their oxygen drops, you uncap it immediately. Then you might have to downsize, put in a smaller tube to let more airflow around it, and you try again in a few days. It takes a lot of patience.
Wow, it really highlights the stakes here. We started this deep dive talking about survival rates and medical protocols, but the real story seems to be the cost of that survival.
That is the takeaway. Whether it's the radiation scarring the voice box in the name of preservation, or the radical surgery leaving a patient unable to lift their arm, or the track tube stealing their sense of smell, the cancer leaves a mark.
It's not just cured or not cured.
No. The victory is real, they are alive. But the patient carries the battle scars every single day. The shoulder syndrome, that raspy voice, the scar on their neck. Those are the permanent reminders of the trade-off they had to make to live.
A sobering, but incredibly important look at the reality of head and neck oncology. It certainly makes you appreciate the complexity of the decisions that doctors and patients have to make. Thanks for guiding us through all of it.
My pleasure.
And thank you for listening. Stay curious, and we'll see you on the next deep dive.